Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Hello everyone, and welcome to our statistics podcast entitled Lies, Damned Lies and Statistics. With me as the guest is Dr. Lisa Goudman at the University of Brussels, where she's a clinical researcher and has published an ever-increasing amount of work in the field of neuromodulation. Welcome, Lisa.
Thank you very much.
This podcast I think I chose to have as a topic because I have found statistics invaluable in my everyday professional life. And I've come to a knowledge of statistics quite late. I remember my undergraduate statistics course done in the first year of medical school, where we had a professor talking in a monotone and we would just throw paper airplanes from the back of the room down to him at the front, which obviously is very disrespectful and I wouldn't do that now. And I finished medical school with zero knowledge and have clearly needed to gain it over time and recognise the benefits. So I suspect my journey will not be too unfamiliar to other people's journey that's come over time. So with statistics, again, perhaps I was a little bit naive, but I assumed it was all simple, all straightforward. You looked up a little book, it told you which test to use, and there was never any question about how things should go. And what I've realised is that statistics is as alive and as controversial as any other area of medicine. And there is nuance and there is clinical background that informs you of which way to go. And I guess the most shocking for me has been looking at papers and realising that it said something is true, but inside it's actually false. Have you ever come across that as an example?
Yeah, I definitely like the way how you are framing it, like it's true or it's false, and it's exactly as you say, there is no right answer. And I do get the point that sometimes you go through the methods and you derive one answer from it, and then suddenly you go or you dissect the article, you read the discussion, and you see that the interpretation from the authors is completely different from what you derived yourself from the results. So I do get the point that sometimes the results can claim one thing, and then in the discussion you get a completely different story. But I think that's the nature of statistics, and especially of biostatistics, since there is a broad variety of topics and the clinical experience is of crucial importance. And I think that's where you need like the combination of someone with a medical background and someone with a statistical background, and that's the biological or the medical background is crucial to correctly interpret the statistical or the more analytical output of a certain model. So that's why I think that sometimes there is like a discrepancy, since we are probably not interpreting the models in a correct way due to, from the side of the statisticians, a lack of clinical background, and maybe from more medically schooled people, like a lack of more analytical knowledge or statistical knowledge.
So I think many practicing doctors often feel that they're underdone or they lack an adequate statistical knowledge. Sometimes they'll say, look, I'm no better than a medical student in terms of what I would know. How would you advise somebody to go about gaining knowledge in terms of statistics, interpreting statistics, feeling comfortable to read a paper, for example? What way could they go to get better knowledge than what they have?
First of all, I think it's a very gradual process. I don't think that you can say from one day to the other, I am now someone who is perfectly capable of knowing or understanding everything from statistics. And that's perfectly the same with being a physician. It's not because you're graduated that you know everything and that you're the expert in the field on a specific pathology or intervention. I think it's really a gradual process, and that you need to accept it, that it takes time, and that it's not something that you can learn from only theoretical knowledge. Since I think that there is also a difference between theoretical knowledge that you can derive from like reading a lot of books, the more theoretical background, but then you still need to translate it. And you often only encounter problems when you're trying to program it yourself, and then suddenly you see, oh, I didn't thought about this or that. And then you need to go back to the textbook, like, how do they solve it? Is there an answer? And then the most difficult part is there won't be one answer. There probably will be a second plausible option as well, or a third one, or a fourth one. And that's maybe the difficulty with it. But if you want to start learning a lot about statistics, I think the internet is really our friend in this case. There are really a lot of tutorials. For example, DataCamp is a great one. They do have like practical examples that they say, this is a hypothetical situation. You can simulate the data like this so that you really have data that you can work with.
Right.
This is the coding, so this is what you need to do. Then you can do it yourself. And they also help you with the interpretation. So you basically see within their courses, like, this is the interpretation. What is the explanation or the interpretation of this coefficient, of the R square? Like, they definitely explain everything. And that's a crucial part as well, like to not only see the analytical output, but understand it also. So that's one way, like relying on the internet. Of course, also relying on books, that's also a really important one. Maybe something that is more personal, like during my education, I was forced to enter a competition. It's called Kaggle. It's like a platform that is online, and you do have a lot of data sets over there. And the idea is that you are competing against all the other people who are on the forum, and you need to create the best model. And that's basically how you learn a lot, because you are forced to make a model that is better than your peers who are in the group, and you're constantly learning from each other. And there is also a forum so that you can see, how did they solve it? Okay, I'm gonna embed that in my thinking, in my model. So I think that it's also of importance, like, to do a lot of stuff yourself. It's like a very practical discipline, and not only an analytical discipline. So it is related to the mathematics, more the theoretical framework, but also a lot to the practical.
I think you made an excellent point, which was that as clinicians, we make a lifelong commitment to learning new medicines that comes along. We would never say, I refuse to learn anything ever again. So it's just natural for us. And we should probably have the same approach to statistics, because that will change over time. You know, many of the things, meta-analysis didn't exist when I was at medical school. I go back that far. So that's something that came along after medical school, which to me was fascinating. It's kind of obvious now, but at the time it wasn't obvious. So it's a lifelong commitment to methodological analysis at the same time as clinical care.
Yeah, that's basically the same analogy. I fully understand you. Like, you need to commit and understand it, and also accept it, that you're never gonna have your knowledge, and that you can say, oh, this is the point where I know everything. For example, I also have the experience, oh, I didn't know this test. I have to look it up, even when you studied biostatistics as an education. So it's perfectly normal, and I think that it's also important that the field keeps going further and continuing, because the meta-analysis, we now even have like specific types of meta-analysis, so we can't think about a world without meta-analysis right now. So I think it's important that the field keeps evolving and evolving. Exactly the same thing with medicine. They are really aligned, and I think that they can reinforce each other and make both fields stronger.
So if you've gone through the process, through either going on a course or reading a book, or even just reading reference journal articles, you have some basic knowledge. But then the next step is the application, I guess, of the knowledge. So what's your advice to people on how to start to take the methodology of a paper and analyse it? How should they go through that process?
I think it's really important to dissect the methodology of a specific paper, so that you really take the paper, print it out, for example, and really underline the key aspects, and that you look them up on the internet, because probably the statistical analysis section is really brief in an article, and they only mention a couple of keywords. So I often have the feeling that we know the broad concept, what the authors did, but not really the small details. And I think if you're beginning or entering in the field of statistics, that it might be a little bit confusing, that you only see a specific couple or a couple of key terms, but that you don't know the real details. So I think it's important, like when you read something, that you look it up on the internet or in a textbook, that you really understand what is this model doing or what is this test doing, that you think it through, and that you then try to see whether this is also implemented in the results in the way that you interpreted it. Like, is there an automatic translation and can you see it? And I think it's only by reading through articles that you can learn it. And once you feel confident and that you can really understand the statistical analysis from a paper, that you can then start and really do it yourself, because I'm still convinced that you need a practical experience to really master it. So I think there are like two levels. The first one is really understanding what everyone is doing, and then the second level is more doing it yourself, trying it out, and don't be disappointed if it's not the right answer from the start or from the beginning, or you don't get something out of it, or it's more difficult than you thought it would be initially. So,
in terms of if you've been involved in some clinical research and you have a study, it's often the scenario that we might have a senior person, a professor, and we're the junior person, and we can learn and observe as we go. So there's statistical expertise there. But some of the time you might have done your own research as a junior person and you're having to choose the work. How do you then choose the right test? Do you involve a statistical expert to be a co-author, or do you reach out to somebody who's a friend who has better statistical experience? What are the ways that somebody could do that if they don't have the backup of a professorial unit behind them?
I think it's a very difficult question, and also a strategic one, since sometimes you can have a different opinion compared to your mentor or your supervisor. Sometimes I think that you need to follow the directions. So if you do have the liberty and the freedom to speak, and I hope that everyone in our community has the freedom to say whatever they think, then I think you should be capable as a junior researcher or as a junior physician, a fellow, person who is in training, that you say whatever you think is the right answer, because there is simply no right answer. It's not that your mentor will automatically know the answer better compared to you, because there is no right answer. There can be two approaches, and maybe you can combine both approaches, that you try it out with the first approach, also with the second one. And then, of course, that you correctly report both approaches, because otherwise we are going into the field of cherry-picking results, and then it probably comes to your title that statistics are equal to telling lies, which is often stated like that. But I do think that a proper discussion is key. It can be among clinicians, and if you do have the opportunity to reach out to someone with a statistical background, for example, at the university, then I do recommend it. I know that sometimes people are a little bit reluctant because they are afraid of the translation, because they need to translate their clinical problem and dissect it really through to the basics. They often like to tell like a lot of details, the clinical context, but for the statistician who is sitting on the other side, they only want to have the bare details, the raw data, and that's probably not what the clinician is really telling at that moment. So they need to be capable of translating the research question into a more analytical one. And I think if you do have the capability and the opportunity to do this, then I think it's definitely great, like, to involve a statistician to see at least their point of view and to see whether they can help you, like, to tackle your problem from another approach. It's not that I think that you can only have a good paper if you involve the statistician, but if you do have the opportunity, then I think I can recommend it just to have another point of view. I think if we're collaborating, like with the team spirit, teamwork, that's also like when you make a clinical decision, if you do have a lot of different opinions, then maybe you can create a more solid answer or have a better treatment for a patient. So I think it's the same with like statistics. Do get a lot of different opinions and see where it will bring you.
So before we get on to sort of talking a little bit about statistical tests and techniques, again, it's something I came to late, which was that I never thought you had to stare at the raw data, because that would actually not be useful because it hadn't been interpreted yet. So it had no meaning or value until it was interpreted. And I kind of learnt that actually staring at the raw data is where you should start to look at. Perhaps could I ask you, what is the benefit of that, of actually looking at just the actual numbers or actual graph? What can that tell you?
I think the first aspect that the raw data can tell you is something about the quality of the data. Because when you only look at the figure or at the summary statistics, for example, the mean, the median, interquartile intervals, confidence intervals, you do get an impression of the data, but it's on a very aggregated level, a global level. If you do have the raw data, you can estimate whether the data are reliable, whether the quality is fine. Also, for example, whether there is a lot of missing data, because if you only look at a summary statistic or at a figure, you don't know whether, for example, 50% of the patients didn't complete a specific questionnaire. So that kind of data you can only get out of the raw data. On the other hand, I think it's also important to see, especially in our times now, whether the data are not AI generated. Because it was only yesterday that we discussed it also at the Congress. Can data be AI generated? Do we need to be afraid of AI at our current time period? And I think that's something that you can only derive or get an impression from it when you definitely evaluate the raw data of it.
I recall a paper, I can't the exact one, but it was saying, above this certain level, there's a 20% increased risk of X. I actually looked at the raw data and saw that actually at 3 times above that level, there was a 90% chance of that risk occurring. And that actually was clinically really important, that above this level, it's going to happen to you. You are going to get this complication. And so therefore that is a clinically relevant cut point. Just the 20% average increase didn't tell me something useful. And that's when I started to realize how important the raw data is. Perhaps, Lisa, if I can just throw a couple of different tests at you and get some commentary around that. And I'll try and pick ones that I think might be sort of clinically relevant. So, again, one that was revelatory to me, number needed to treat. What is it and why is it useful?
Yeah, I think a lot of physicians are familiar with the number to treat, the number of persons that you need to treat to have a positive response. And I know, especially in the field of neuromodulation, we often say it for a specific type of pharmacological agents, but then also compared to more interventional approaches, should we switch towards an interventional approach to have a better result? So I do think that number needed to treat is a statistical measure, but I think it more often has a clinical interpretation, and that probably clinicians are more used to work with the number needed to treat compared to, for example, statisticians, because they do not have the practical implications of a number to treat. They are not going to develop a new statistical model or new techniques to derive specific results. They are not always bothering about the clinical interpretation, and that's exactly the interest of a physician. They do want to get the practical knowledge out of a statistical model. So that's one of the examples that I think everyone in this world of neuromodulation is familiar with it, to get an estimate and to guide probably your clinical decision making and see whether you can treat a patient with a specific therapy. So basically everyone is relying on statistics, and probably they don't always think about it, that they are really relying on a statistical model to treat patients.
The next one is odds ratio, and when I was young, you have a big data set and the odds ratio is 1.03, but statistically significant, and I used to think, well, then you have to avoid that because your risk has gone up or whatever. And then slowly they taught me that, well, actually, meaningful is odds ratio of 2 or more, or 4 or more, or 5 or more. So what's the benefit of odds ratio, and when should we really take that seriously?
I think that's a really difficult question because I personally refrain from relying on a specific cutoff 1.5 or 2 or 2.5, because I think it's really specific for the data set you are working with. I don't think that you can generalize it. When I have an odds ratio, for example, the 1.03, but there is a confidence interval that is really, really, really narrow, then probably it will say more than a larger odds ratio. I know there is a gradation, and the larger the odds ratio, the more it will tell. But if there is a really broad confidence interval, then maybe you need to be very cautious with making a conclusion that it will always be X times better compared to a smaller odds ratio. So I'm not a big fan of like using a strict cutoff, and I do get the point, of course, that a higher odds ratio is better with respect to a clinical interpretation, but I'm a little bit reluctant to like make a kind of a rule of thumb, if I may call it like that. So I'm a little bit afraid of that.
Meta-analyses, we have them, and sometimes you can see in the meta-analysis that one study is a huge N and actually is responsible for the major outcome. It's easy to take the meta-analysis at face value, but sometimes when I see that one study predominates, I have to go read that study, because if I'm not happy with the methodology of that study, that changes everything. So when do we trust a meta-analysis? When do we not trust a meta-analysis?
Yeah, it's exactly as you state, like the kind of articles that are included in a meta-analysis, they definitely make like the quality of a meta-analysis. That combined, according to my point of view or my perspective, also with the in and the exclusion criteria that the author stated, because sometimes you have a specific idea in your head that you want to prove something, and maybe you are like changing the in and exclusion criteria, for the articles that you want to include, so that you know, okay, if I include that and that and that article, then my meta-analysis will point towards this direction or that direction. So I think both of them are really important. I think if you do have a meta-analysis, then it's also important to look at, of course, the results, so that you really look at the forest plot and see, is there a lot of variety within it, so that you get the results of every individual study with the mean effect size, and that you see, are they all on one side, are they on another side, are they all over the line, or are they really very narrow and close to each other? And then you often get a measure of like how widespread are the results, and what is maybe the influence of one study, because you always give like a specific weight to each study, and maybe the study that has a poor quality, if I may say it like that, has a large weight because it may have a lot of participants that are participating in the study, and then it will drive the meta-analysis or the results into one direction that may be the complete opposite of the other studies. So I think that it's important like to check whether one study is very influential, especially if it is pointing towards a different direction compared to the others. So that's something that we definitely look at, the heterogeneity within our meta-analysis, to see, can we explain the results, and are there a lot of other factors that maybe we didn't measure and we didn't encounter within the meta-analysis, but that we should collect them to better understand the results of the meta-analysis. Another thing, and we discussed it previously with the raw data, if you do have the raw data, then you can definitely be sure that the quality of the meta-analysis is great, because you can check the data yourself, you can really see, are the results valid, and can we definitely work with it. So that may be another point, that when you do have a meta-analysis, that you try to check out, is the raw data available, can I see something, and is there like a broad line within the conclusions, are they pointing into the same direction or not? And if there is like one study that is pointing towards a different direction, can you explain it from a clinical point of view? And it may be possible that there are opposite results and that there is no consistency in the results, but there may be a perfectly solid clinical interpretation for that, and then I don't see a problem, and then it wouldn't be a quality or a lack of quality that is underlying the meta-analysis. So I think the clinical interpretation is also important to like see whether the meta-analysis is valid, of high quality, and whether you can use it or not.
This thing called network meta-analysis, where magically we can compare A against C, where there's no A-C study, but we derive that via A to B, B to C. Is this a valid thing? Is this something we should rely on in the clinic? Well, what's your interpretation of this as an advance or not?
I think the network meta-analysis are really important nowadays, because there are a couple of network meta-analysis that are published within 2024, 2025. So it's really a topic that is up to date. We also have one with the group of Frank Hage also has one, and I know there is still another one on its way. So there are a lot of network meta-analysis, and I think they are important because the basic principle is that you only include RCTs. RCTs, we all know them as the gold standard. They do have a high quality, or at least we expect them to have a high quality. And the basic idea of the RCT is that you have 2 treatments and patients are allocated in a random way. And the random aspect, that's the crucial aspect for a network meta-analysis. So within a network meta-analysis, you combine a couple of RCTs, you put them together. But the main assumption is that you say that all the treatments are allocated in a random way, and that you did not say, oh, that type of patients, we will give them that treatment, and the other group of patients with, for example, higher pain scores, we are more inclined to give them, for example, spinal cord stimulation compared to like just a conservative treatment. So the random aspect is really crucial within a network meta-analysis. And I do think it's important because, as you stated, you can compare different treatments even if there is no real evidence. So the basic idea is that if you do have an RCT for conventional medical management and also like the tonic stimulation, you also have one about tonic stimulation and paresthesia-free stimulation, that you can, since all interventions are allocated randomly, also estimate the association or the strength of the relation between like the paresthesia-free and the conservative medical management. And this basically causes that we do not need to do a lot of additional RCTs if we want to derive meaningful results. So I do think it's really valuable and that it can help us within our field of neuromodulation to like prove that our therapy is really working, especially with like the ethical concerns. If you want to provide some kind of a placebo treatment, then maybe it is not ethical like to give a treatment to patients and you know the treatment will work and the other treatment will definitely not work or will be inferior compared to what there is already on the markets. Then a network meta-analysis may be a way like to circumvent making that difficult RCT because you can rely on evidence that is already there. And I think that's a major advantage, that we can rely on evidence and not need to redo or do a lot of additional analysis to derive meaningful conclusions, because the network meta-analysis really has like a high standard because you only include high standard analysis. So. But of course, if the RCTs are not having a high quality, then the quality of your network meta-analysis may be questioned as well. And then we're like on the rough terrain, like, are we gonna trust it? Are we not gonna trust it? The criticasters can also say like, oh, but they only included articles with a low quality, and then we need to be very cautious. So I think a network meta-analysis can be a strong and a powerful tool, but that we need to be cautious and only include like high quality research within it, so that we don't give everyone like a reason to say, they only have low quality evidence, and that's why we don't need to trust the network meta-analysis.
So I just mentioned a few, but from your perspective, is there anything else that's an important test or technique that you think clinicians should be aware of?
Something that I found really intriguing, if it's not in a paper, if the authors did a lot of different tests. They do one test, then they do another, they do a third one, a fourth one, and suddenly the 10th test that they conducted is statistically significant. And they do report all the tests, but they only have one aspect and one test that was really significant, and then they write the full manuscript about that one test. So I think there are two ways, like you can say it's really cheating, and that's the title. Statistics is all about lies.
Lies and statistics,
cheating, it's cherry picking, fishing, because maybe you want to find that one particular result. So that's something that I'm always a little bit reluctant from, and I do think that you need to correct for all the different tests that you do. So a correction for false positive results or for multiple testing, that's something that I found really important, and I think most of us within the field are relying on what is called a Bonferroni correction. So the basic idea is just that you have your classical p-value, or 0.05, and that you divide it by the number of tests that you conducted. So if you conduct 10 tests, then conduct it by 10, but then you're really very strict and conservative, and the probability that you will find a result on your 10 test will be really low if you use the adapted, if I may call it like that, p-value, compared to the classical one of 0.05. And That's a concept that I really value, and I think it's really important. And I think we should focus more on this aspect. I'm a little bit afraid that sometimes we do a lot of tests and that we put too much value on the one result that comes out of the paper, because it might be related just because you conducted a lot of tests and that the result that you obtained is not really true. And that's something that I'm a little bit afraid of, but you can never prove that it's really a result that shouldn't be there from a clinical point of view. So that's always the thing that, I find it difficult, and I'm really cautious, and I can recommend everyone to check it out and see whether you need to correct for multiple testing.
So it occurs to me that if you're in the hospital department or university department, you have a journal club and you're talking about a journal, should it be compulsory to also talk about the statistics as part of your presentation of the journal article?
I think that the statistics should be a component of discussing an article, because you cannot discuss only the clinical aspect if you're not 100% sure that the methodological aspects are really clear. And I think that if we start discussing the statistics more, then maybe everyone is more familiar with it, because I sometimes have the impression that if you say I'm a statistician, that everyone is saying, ooh, that's not our cup of tea, and be on your own planet, and we're more clinical, and that's not our thing. So I think that sometimes we have a negative connotation, and I don't think that's necessarily true. I think we can embed the statistics more within the clinical field, for example, by having a journal club and also making statistics accessible for everyone. It's not that they are complicated, it's not at all. They're really logical, and there is a basic idea and a rationale behind every statistical test. It's just that we are not used to think that way, and we don't get it within our education. And it's basically a pity that we are forced to learn it later on within our lives and rely on self-study just to get most out of medicine as well, because you need the statistics to interpret it. So if there is a possibility to have a journal club and it's also focusing on the statistics, I think it will make everything more accessible. And that's exactly what the journal clubs within our field are doing. They are not afraid of the statistics. They discuss them as well. And maybe we should expand towards a full discussion about the statistics as well, so that everyone is more acquainted with it and is more familiar with it.
And to your point, I guess, in the clinic, I've become more and more statistically minded with clinical care. So when I'm looking at this diagnostic conundrum in front of me, why has this person got pain? I try and use this thing called Occam's razor. I try and look for the one explanation that would explain all the observable things in front of me, rather than say, they've got 3 diseases. It's probably less likely than they've got 1 disease, if you like. So, and I also will try and think in a Bayesian manner. So I'll try and think, what's the likelihood before I start that they've got X? And now, if I do this test or this MRI scan, or what does it change anything? And if it doesn't change anything, why am I doing the test? Kind of thing. So, but I found other people perhaps struggle to have a statistical mind in the clinic, that they're a bit divorced. How would you encourage people to try and almost bring statistics into their daily clinic life?
I think, as you explained exactly, that a lot of people are making statistical conclusions and relying on the data. For example, with the Bayesian analysis that was pointed out, look, you are basically constantly updating your own belief based on additional data that you retrieve. So in a clinical setting, when you see the patient for the first time, you probably have a limited set of information. Mm-hmm. Then you send the patient towards imaging or another discipline.
A diagnostic test.
Yeah, a diagnostic test. You get the information back, and then you will adapt your reasoning based on the additional data that you have. So that's basically the principle of Bayesian analysis. And I think a lot of people are maybe doing it intuitively also, but they are not really realizing that this is a statistical principle that they are using. I think we can maybe reinforce statistics within clinical reasoning just by relying more on, for example, the network meta-analysis and embedding the results of scientific literature more within clinical practice, or more thinking about the literature point of view as well when you're clinically thinking about a patient, because sometimes there is like a discrepancy that a certain patient is not exactly fitting what is in the literature. So I think you are like always having a combination of the statistical point of view within your clinical reasoning without even realizing it. For example, for safety aspects, we all know from the literature, like a pedal lead or percutaneous lead, which one has like a higher reoperation rate, the higher the costs. That's all relying on health economics and on statistics, and it's basically embedded within the daily functioning. Like, are you gonna implant a pedal lead or a percutaneous lead? It's just not, we don't think about the underlying models when we're making that decision.
And we also see some researchers who will publish something, but it's not useful to the clinician. So, for example, somebody publishes this phenomenon has this risk factor for a poor outcome from spinal cord stimulation, and this has another risk factor, and this has another risk factor, and they'll give you the score for the risk factor. But in a clinic, what I really want to know is, if this person has 3 risk factors, what's their chance of failure? 2 risk factors, what's their chance of failure? 1 risk factor, what's their chance? No risk factors, what's their chance? And then I can start to cut off or communicate to the patient the risks, but I can't have that because of the way they presented the data. How can we encourage researchers who write papers to bear in mind the clinician who's going to use the information? Sometimes there seems to be a disconnect.
Yeah, and I fully agree, and it works both ways. Then it's basically like a person with a more analytical mindset that created a paper, and they didn't thought about the full clinical implications. So it's not always that a clinician is not translating it correctly towards a statistical method or the analysis. It can also be like that the persons who are doing the analysis are not translating it towards a clinical interpretation. And I think that's a crucial aspect, especially since we are in a clinical field. And we are not like a field where we are trying to create new statistical techniques. Then I would say, okay, the clinical interpretation is less important because no one is going to use it. Within our field, we are definitely relying a lot on prediction models, because what does a physician want? They want to know for this specific patient with indeed those risk factors, is this treatment a valid option, or should we maybe go for another model or another treatment? And that's basically like the individual responses, and that's relying on the clinical reasoning. So I do think we need to make the clinical implications very clear and very straightforward to get the most out of our results, because if we're not making the clinical interpretation as an author ourselves, then I think the paper will never, or you will never get the most out of a paper. And I do think it's the responsibility of the authors themselves to, like, if they don't have a clinical author on board, like, to get a lot of clinical input, to get clinical authors as well to interpret their results. And some people will maybe argue that it's the clinician or the person who is reading the articles that should make like the translation towards the clinic. But I do think that it are the authors, because they know the details, they know the insights, that they should be capable of making models and creating implications that are valid for clinical practice. And if there is a specific cutoff that is important for making a clinical decision, yes or no, then I do think that these should be incorporated within the models as well, so that we create clinical models that are relying on the medical field, and that we're not only like creating a model just because we can create it from a statistical point of view. We should take into account the clinical aspects when already designing the model or thinking about what are we gonna do and what do we want to achieve. I think the end goal should always be in our mind, and that we can like make an analysis that will answer a clinical question, and not that we can do an analysis and that we come to something that is basically so far away from where we need from a clinical point of view. So I think it's crucial to have the collaboration between both of them to get the most out of it.
And it's so much easier to do that before publication than after publication. So when I'm reviewing for the journal Neuromodulation, I sometimes think the best thing I can bring is to be a clinical Sherpa and say to the authors, could you please reinterpret this? Could you please change this to a table, a rule-based outcome, so that then this can have clinical use. So sometimes I find that's more use than anything else I could contribute in the reviewing of the paper. Lisa, you have a formal qualification in biostatistics. Do you think the formal qualification pathway is useful? And who should pursue that?
I think it's really useful, and maybe to give some details about my personal background, I didn't have a biostatistical background in the beginning. So I started my PhD and I needed to rely on EEG analysis. And I have to admit, I didn't know anything about EEG analysis and how to interpret the data. And I met a lot of people and they all said, you need to be capable of programming. And then the bells started ringing, like programming, oh my God, I'm not capable of programming. And that's when I started to get into statistics. And then I obtained like a master in statistics. And then I went to biostatistics and epidemiology because I think they are all related, but really, really important for our field. I do have the feeling that now with the qualifications that I'm more capable of like getting the most out of the data. And sometimes we just have to think, and that there is no clear-cut solution. It's not that when you have a qualification in statistics and you do have a clinical problem, if I may call it like that, that you immediately know this is the answer. Sometimes it takes a little bit of time and that you need to think through a couple of possible pathways to get the most out of it. And I do have the feeling that our research has improved since we can add more the analytical reasoning and combine it with the clinical reasoning. So I do have the feeling that by going through the pathway of a more statistical background and by getting the qualification, that we can get more out of the data and that we sometimes get a different perspective on the data, and that we can get a different result just by looking from a different angle at the data. So I can definitely recommend it, and I don't think that there is a perfect time point when you can or you should invest within statistics. And it's not that you always need like a full qualification. Sometimes a summer school is also valid if you do have a very specific question. For example, you want to do something about survival analysis, to say something if you want to have a Kaplan-Meier plot, then you can maybe invest for a 1 week period or just a lot of evening schools during a 1 or 2 week period to learn about it and to really master the skills of like a survival analysis. And I think that's also really valid, that you maybe just like be very selective and point out the aspects that you really need and that you need to make your article stronger. So that may be an option as well, that we do not all need to qualify and get everything out of the statistics, but maybe just be a little bit more selective and to get the most out of it.
The Holy Temple is the Department of Biostatistics in the university. But to me, there seems to be a disconnect between the people that live in that temple and the people at the coalface. Why do you think there's such a disconnect between that group and clinicians wanting to use statistics?
I have the feeling, and especially also at our university, that the statistical group, that they are also working on statistical models and the new techniques and seeing whether they can improve the field of statistics.
Cutting edge.
And not only, the field of medicine. And they do have, for example, at our university, a lot of consulting, but I think those are two separate pathways, that you have the discipline of statistics as such, if I may call it like that. They want to get more out of the fields, the analytical field, and then you have a different field like the statistics who will work and who will provide consulting fees and or services, I should say, and that they are the ones who are collaborating with the researchers, and maybe that translation is not always made. And maybe the persons with a statistical background are more interested in getting more of the out of the analytical field compared to interpreting clinical data. I think it all depends on whatever they want to do, but I do understand the feeling that sometimes they're on separate islands, if I may call it like that, and that we should more invest in the collaboration, because we both need each other basically to get more out of it. I think it's based on what they want to do, and that sometimes the expectations may not be fully aligned to get the most out of it.
So to wrap up, can I ask you, the INS biostatistics primers, which there's now quite a few and many more in the pipeline, a little bit biased comment, but what do you think of that?
I know there is a bias because they're coming from the group of Australia, but I definitely like them because they are really short. So it's not that you need to have a 1 hour time period to go through the article. They are to the point, very specific, and they very often start with like a clinical idea or a clinical setting so that you can immediately grasp the importance. It's not that it's a far-fetched statistical technique, it's really to the point, clinical. You can immediately apply it to your own situation, and then they work through the example. And they also state in specific articles, those are common misinterpretations, or those are really important factors, or this is a summary box that you should rely on if you want to interpret a specific test. And I think that based on their formats, that they are really, really accessible, and I highly recommend them. I'm, at least from my side or my perspective, a huge fan of the papers. So.
And for INS members, there are a service that's available on the INS website. Lisa, it's been an absolute pleasure talking to you today. As always, thank you so much.
Thank you very much for the invitation.